Thank you again, everyone, for joining us this evening. This is the panel discussion about future therapies in cardiovascular research organized by Cambridge Cardiovascular for the 2022 Cambridge Festival, and Wellcome. So we all know that cardiovascular disease is an important cause of morbidity and mortality worldwide, and clearly there's a need for better therapies for addressing this global health need. So tonight we have a fantastic lineup of 4 experts who are going to talk about the breadth of research coming through Cambridge in terms of novel therapeutics and approaches towards tackling cardiovascular disease. Without further ado, we'll get started. So the first speaker we have is Dr. Mary Nuss, who is a BHF Intermediate Research Fellow in the Department of Medicine. Dr. Nuss is going to speak about how to turn science fiction into reality to treat atherosclerosis. So over to you, Mary.
Thank you. Let me share my screen. Okay. Thank you, Jason, for the introduction. So I'm Mary, and I'm mostly a lab-based researcher in the University of Cambridge in cardiovascular diseases. And this is why I'm going to tell you how we are trying to turn science fiction into a reality to treat atherosclerosis that, despite looks like a complicated work, atherosclerosis means that the blockades of the arteries. So cardiovascular diseases are the main cause of death worldwide. And for example, in UK, every 5 minutes, a person dies of a heart attack or a stroke. And even if they survive to these events, they can develop a long-lasting diseases like heart failure or vascular dementia. In general, in the majority of the cases, the underlying cause is atherosclerosis. That is these blockades of the arteries. That this disease is triggered since birth and mostly due to many factors. It can be due to an imbalanced diet or consumption of tobacco or high blood pressure or even genetic factors. And for many years, we have thought that this was just a passive disease in which there was an accumulation of fats and lipids in the inner part of the arteries. But now we know that it is a complex inflammatory disease, and these plaques are not only full of lipids and fats, but they are full of immune cells. That they are not only accumulating fats, but they are also secreting pro-inflammatory cytokines and releasing this into the blood that then are going to activate other immune cell organs like a spleen or lymph nodes. And this is going to make a person to have a systemic inflammation. We don't know when or how or which plaques are going to break, but sometimes these plaques break and they release this thrombus that if it reaches the brain, we will have a stroke, and if it reaches the heart, we will have a myocardial infarction. So when a patient arrives to a cardiologist or a GP and they are known to have high cardiovascular risk, that this is measured by different factors, but mostly also by the levels of cholesterol and the inflammation and some inflammatory factors in the blood. Then we are very lucky because a few years ago, it was discovered these drugs that are called statins, that they have reduced a lot the risk, the accumulation of cholesterol in the arteries. But they are not enough. And there are still some people that they are still having, despite this treatment, high cholesterol and low inflammation, and these are patients that have residual cholesterol risk. And for example, now some drugs like PCSK9 inhibitors have been developed to target this population. But also there is another high amount of people that despite they reduce their cholesterol levels, they are still having high inflammation. And these are the residual inflammatory risk patients. And there is only like a 15% of the patients that respond only to statins. All the others will need other therapies. And I'm very focused in the ones that have a residual inflammatory risk. And a few years ago, now 5, it was the first clinical trial in which it was demonstrated that atherosclerosis is an inflammatory disease. And this was in this clinical trial called CANTOS, that they were targeting a pro-inflammatory molecule called interleukin-1 beta, that and on top of the statins, and they were able to reduce the inflammation. And as you can see here in these graphs, they were also able to reduce the a new cardiovascular event. The reduction was significant, and you might think, but it was very small. But in reality, now that we have all become epidemiologists since COVID, now we know that even a very little percentage, when it affects a very big amount of the population, can translate in a very big amount of people that have benefit from these treatments. So the only problem of this treatment, it was that it had, and it wasn't approved, is because it developed a side effect infections. Because of course we are targeting the inflammatory response, and this the immune cells are necessary to fight against pathogens. So many of these patients were developing severe infections and even fatal infections. So how do we need to target to avoid this? How can we avoid these systemic side effects? So we believe that we need to target specifically certain cells, and even not only certain cells, but even only certain properties of the cells, to be able to be more specific and not affect their properties for protecting from pathogens, but only their properties affecting atherosclerosis. And I work in these 2 immune cell subsets that they have very complicated names, but they are really cool because they are called marginal zombie cells and T-follicular helper cells. And we have discovered that these are 2 cell types that are protective because they are responsible to produce the protective IgM antibodies. And now we are going to try to target them, but not to remove the whole cell population. We want to target them certain properties because we are identifying certain genes that can be modulating these atheroprotective properties. And we want to make nanoparticles that are this thing that you can see here, that nanoparticles are very little particles that we cannot see by the eye, and that they have in their surface a molecule that will bind specifically to a receptor, for example, that is only expressed in this cell type. And then when it arrives here, it will be it will get into the cell, and there it will secrete, for example, a silent RNA. And the same we can do with the T cells. We can do it both in vivo or even in vitro, that like they are doing now for treating cancer with the CAR T cells. Another way I'm studying how we can target these 2 cell types is through gut microbiota. And this gut microbiota, I'm referring to the millions and trillions of microorganisms we have in our bowels. But again, of course, we cannot target the whole gut microbiota because this will have effects that we don't want them to happen. So I'm trying to identify which are the species and the molecules that this gut microbiota is releasing and are going to modify the properties specifically in these cells. And now, thank you for your attention, and I will be, when we finish all this, willing to receive any questions you may have about my research. Thank you.
Thank you, Mary, for that excellent talk. As Mary mentioned, we'll take questions at the end. There'll be a in-depth panel discussion, and I would encourage everyone to type their questions into the chat box so we can help facilitate this discussion. So next up, we have Dr. Nicholas Evans, who's a consultant in stroke medicine, and Nick is going to be talking to us about teaching old drugs new tricks. So take it away, Nick.
So thank you, Jason, and good evening, everyone. So my name's Nick Evans. I'm a consultant in stroke medicine at Addenbrooke's and also a researcher in stroke medicine at the University of Cambridge. And it's a pleasure to be here to talk a little bit about some of the research we're conducting here in Cambridge. But as Jason's alluded to, I'm first and foremost a clinician, and I want to sort of pick up on what Mary just said, which is in the course of the next 5 minutes, somebody in the UK will have a stroke. That figure will rise to 300 by this time tomorrow, and by the next Science Festival, that figure will have risen to around 110,000 strokes. It's one of the leading causes of adult disability here in the UK and affects not only the individual, but their families, carers, healthcare, and the UK economy as a whole, with an estimated cost of around £26 billion per annum. So the scale of the problem we face is vast. Now, a major cause of stroke, underlying around a third of ischemic strokes, is carotid atherosclerosis, the furring up of the main artery going up to the brain, the one that you feel when you feel the pulse in your neck. And as Mary has already explained, is that rather than this being a sort of benign accumulation, sort of a furring up within the arteries, like limescale in a pipe, actually this area of atherosclerosis is a nidus for inflammation, and it's triggered by the cardiovascular risk factors with which we're all familiar, of smoking, high blood pressure, high cholesterol, and diabetes. And as Mary has said, when that plaque becomes inflamed, it becomes damaged, a clot will form on the surface and will travel up into the brain to cause a stroke. But the difficulty we have within clinical practice is that the conventional imaging that we use of either ultrasound or ultrasound Doppler or CT angiograms only show us the degree of narrowing. What they don't tell us is how inflamed the plaque is. And the degree of narrowing tells us only part of the picture. And this is where some of my research comes in. So I'm using a specialist scan that's used routinely within oncology care, but we have repurposed then for cardiovascular research. And this is a positron emission tomography scan, a PET scan. And what this enables us to do is to inject a participant with a tracer, and a tracer binds it to the site of inflammation within the body. So this way we are able to both detect and quantify inflammation within atherosclerotic plaques non-invasively in vivo. I'm conscious that actually there are a number of people who are participating in our studies already on this call, so they'll be able to tell us a bit more about it. But essentially the scan itself takes around 15 minutes. So this is a reconstructed 3D scan of somebody with a right carotid atherosclerotic plaque that's caused them to have a stroke. You can see this area here, this sort of greeny blue appearance in their right carotid artery. And as we should see now, this area of inflammation matches very neatly with the dividing up of their carotid artery, the carotid bifurcation. So that represents a highly inflamed plaque that is unstable and has caused a clot to form that's gone up to cause a stroke. So we can identify this inflammation non-invasively in vivo. But actually, this is far more complex than just inflammation within the plaque. And as Mary has already mentioned, and we're going to be speaking with the subsequent speakers, is that actually this inflammation is diffuse. Yes, the plaque is inflamed, but actually so too is almost all of the rest of the arterial system. You get one area of plaque, but actually the whole system becomes angry and as we're going to hear from Tian, on fire. So here's a scan of somebody's carotid artery. You're looking through from their neck sort of this way through, and you can see here that there's this uptake of our tracer that shows this inflammation all the way along their artery. So all their arteries within their bodies are highly inflamed. So this has important implications for the stability of the plaque and potentially a future stroke, but also as well actually has downstream implications on the organ. So as a stroke consultant, I'm interested in within the brain. And you can see in this individual's case here is somebody with fairly, there's a little bit of inflammation going on within their carotid arteries. This is a slice through the neck at this level. And you can see here up in their brain, this, from my perspective, they've got a stroke there, but actually there's relatively little background chronic damage in the brain. Compare this to this scan that you see here on the right-hand side of your screens. where there's extensive sort of, as you can see here, what we call cerebral small vessel disease going on around their ventricles. And this is important because actually this is associated then with an increased risk of vascular dementia, of cognitive impairment, but also effects on gait, on continence, and actually an ability to lead an independent life. And for these individuals with red hot atherosclerotic plaque suggesting a really high degree of inflammation, we can see this was associated with much more extensive cerebral small vessel in the brain. So in other words, the really hot arterial systems have a downstream effect then on the brain. So what's next then for that, bearing in mind that we can now detect this inflammation? Well, we need to understand this relationship a bit better. And so for this reason, we've designed the Daedalus study, which is supported by the Academy of Medical Sciences. And what this will enable us to do is to do a scan looking at the inflammation within the arteries, but also as well the inflammation going on within the brain to help us understand about how the inflammation in the brain is potentially causing that small vessel disease that we saw in that previous scan. So linking then inflammation throughout the whole body, linking between the blood vessels and the brain. But the bits that I'm particularly talking about today is about repurposing drugs. And a really exciting finding that was found a few years ago is that individuals taking a particular epilepsy medication, sodium valproate, are at a lower risk of going on to have a stroke. And we see that compared with people, this is a Kaplan-Meier curve, this is the people who are stroke-free. So here is the people who are taking the sodium valproate, whereas those who are not taking sodium valproate, there was a much higher risk then of stroke. And it's not just them taking an epilepsy drug, but it seems to be something specific to sodium valproate itself. We see here, again, compared to taking the sodium valproate here, compared to any anti-epileptic drug, those who are on sodium valproate, there's a higher proportion who remain free of stroke. And the reason we think this is that actually within atherosclerotic plaques and inflammation, that there's an upregulation of a very important enzyme called histone deacetylase 9 or HDAC9, which when we look at atherosclerotic plaques, we see is upregulated in these plaques. And sodium valproate specifically inhibits this HDAC9 enzyme, and what we hope is will stabilize the plaque and reduce that inflammation. So that is our SOLVE study going on at the moment that compares individuals who are receiving conventional therapy against those that have the conventional therapy and sodium valproate. In my sort of final penultimate slide now actually is that the other study drug that we are repurposing is Minocycline, a commonly used antibiotic in acne that also as well has anti-inflammatory effects and also as well appears to inhibit then calcification of arteries, which is a downstream consequence of atherosclerosis and of inflammation. So what I've just covered in the last 7 minutes is about showing how inflammation is really a key process in carotid atherosclerosis and how it relates then to downstream brain damage. And what we hope by better understanding this is that we identify novel therapeutic targets, that we improve then the ability to monitor the inflammation using PET imaging to be able to improve our prognostication, or maybe pie in the sky thinking now and potentially the ideal would be for that individual who's had a stroke whilst I've been speaking to hopefully better yet to have stopped them having a stroke at all. So thank you very much.
Well, thanks for that really excellent talk, Nick. That was really great. So next up, we have Dr. Tian Zhao, who is a BHF clinical lecturer in cardiovascular medicine, and Tian is going to talk to us about the heart on fire. Go ahead, Tian. Thanks very much.
Well, thank you, Jason, and thank you, Mary and Nick, for the excellent talk so far, which lead wonderfully into what I want to talk about, which is the heart on fire and inflammation in heart disease. I'm a clinical lecturer at the University of Cambridge, which means I spend half my time doing clinical research at the university and half my time practicing cardiology at Royal Papworth Hospital, which I am tonight. So the heart has 3 blood vessels supplying with blood, And over time, and as mentioned by Mary and Nick, these blood vessels can start to narrow and the blood supply can start to decrease the flow because of the narrowing. If these narrowings get severe and over time, and if they rupture, you can acutely occlude the blood vessel and completely stop flow down into the heart. And the heart muscle that the heart is supplying then starts to die. And that's when people get chest pain. And then when that happens, that's when you call an ambulance and you can come to Royal Papworth. Now, traditionally, we thought all this stuff, this plaque, is due to buildup of lipid only, and that was what we thought for a long time. But actually, over the years, we now know that there are a lot of immune cells in the plaque, and actually, as discussed by Mary and Nick, this is a very immune-based process. There's a lot of immune cells there, and they very much drive the process. In the plaque, and there are immune cells that are trying to stop this and decrease inflammation. There are a few of them, but they're called regulatory T cells. Most of the immune cells in the plaque are there to increase inflammation and to drive the process forward. And for example, are effector T cells here. We know that in genetically modified mice, and if we give them a Western diet, they develop plaque in their vessels. And if you get the same mice and you give them regulatory T cells, you boost their regulatory T cell numbers, they get less plaque. So how can we sort of do this in humans? Well, we know that if you give patients and animals low dose interleukin-2, which is a immune hormone, the low doses can actually increase regulatory T cells, whilst at higher doses they actually increase the inflammatory cells. Well, how can we translate that to patients? Well, as Nick was suggesting, repurposing of medication is a really powerful way to do this, and we can talk later on about why that is. But interleukin-2 already exists. It was approved many years ago for the treatment of cancer at very high doses, but sort of has now been developed to be used at low doses to treat inflammation. So as a result, we developed the Lilacs trial, which is performed at Addenbrooke's for the role of repurposing the interleukin-2 for patients with heart attacks. And the aim was, firstly, safety. A lot of these drugs are contraindicated in patients with heart disease. And secondly, to find a dose to use in our patient group, which can increase the number of Tregs, which are anti-inflammatory, by the amount that we want to increase them by. So the trial was completed and it's published for those who are interested in more detail. But we found that interleukin-2 was safe to be used in patients with heart disease, even though it was previously thought not to be. And the most common side effect was injection site reaction, which is known about, and a short flu-like syndrome, which is also known about. I just show just some of the data here. On this axis, we have the increase in Tregs, which you remember are anti-inflammatory and sort of try and decrease the plaque progression. And we can see with increasing doses at the bottom, in patients with stable angina, you get increasing amount of Tregs. And once again, in patients with heart attacks with higher doses, you get, with doses that we tested, you get increases in Tregs. And with all the doses that we tested, the concern was whether we will increase the inflammatory and the T effector cells, which we don't, which is very promising. So what next? Well, we've completed the first clinical trial. Now we're moving on to the second larger clinical trial where we will test more patients with heart attacks for longer periods of time. And that's the Ivory trial ongoing. And we're about halfway through that study. And this time we'll be using PET-CT, which Nick has already introduced as a concept to look at vascular inflammation and whether we're actually affecting the inflammation in these vessels in the positive way which we want to. Half the patients will be treated with interleukin-2, half with placebo, to see if the effect is real. And then the study is being conducted at Addenbrooke's and Royal Papworth Hospital as well. Now, the second concept I'd like to quickly discuss is that not only is there inflammation in the blood vessel, the heart muscle which dies or which becomes damaged after the heart attack, there is inflammation in that area as well. And what I mean is that very quickly after the heart attack, immune cells rush into the damaged myocardium. Now, there are some immune cells that are there to try and heal the muscle and trying to clean things up and make scar tissue. But there are others that are very inflammatory and can cause more damage. And then one of the cell types that we're interested in are B cells. And you probably know that B cells are sort of immune cells that produce antibodies, but also they're important in orchestrating an immune response. Once again, this is all work done from our group, is led by Ziad Mallet in mice models, that if we give mice heart attacks, we could sort of cause heart damage. But if we give mice heart attacks and get rid of their B cells after the heart attack, they have less heart damage and improved heart function after. So based on this work, we thought, well, how can we do this in humans? Well, it turns out there's already a drug called Rituximab, which depletes B cells. It's used by millions of patients already. It's used in rheumatoid arthritis, lupus, and cancer. But before we tested it, it was contraindicated in patients with heart disease because of unknown safety and potential reports of side effects of arrhythmias and heart attacks. So therefore, we designed and completed the Rita Mi Trial, which was done in Papworth, and we took patients who had the most severe, the largest type of heart attacks, the STEMI patients, who get brought over straight to Papworth. And after their heart attack, after they've been treated, we gave them a single shot of Rituximab, and we had 4 different doses that we tested, and we followed these patients up over 6 months to see if it was safe to do so, what happened to the B cells, what happened to the other blood markers, and what happened to their heart function. What we showed was that Rituximab appears safe to use. We had some side effects, but these are often quite sick patients, but nothing that will seem to be related to the drug itself. And importantly, I'll just show you one of the slides of data is that we found that this is B cells that within 30 minutes of starting the infusion, we could acutely deplete B cells, which is very important because obviously this is all very time critical. We had 4 different doses, and we showed that the difference with the higher doses that at 6 months, we are still suppressing the B cell function, B cell number, sorry, was at the lower dose, the B cells start coming back. So what next? Well, this work has directly led on to applying for European funding from the EU Horizon 2020 fund, which was successful. And we now, led by Ziad Mallet, have a pan-European, larger phase 2 randomized, double-blind, placebo-controlled study in several European countries. And the plan is to get patients with the biggest heart attacks because the STEMI ones, because they have the most to gain from this, and then randomize them to either placebo, which is a dummy treatment, and either one of two doses of Rituximab. We aim to dose about 500 patients, and what we'll do is we'll see by using cardiac MRI or cardiac imaging to see how much improvement in cardiac function they have over 6 months. And this is ongoing. This will start in the next few months. Cambridge and Papworth is participating. We were going to be the primary site, but unfortunately Brexit didn't allow that to happen. So in summary, inflammation and the immune system plays an important role in heart disease. We're developing therapies to target the immune system in patients with disease, which could potentially in the future help improve survival and quality of life. We've completed the early stages of drug repurposing, and we're now on the next stages where we're transitioning to larger and more advanced clinical trials. And lastly, the work is only made possible by patients taking part in research, and we're eternally grateful for all our patients who take part in research, and also our funders who are all medical research charities. And when people want to talk about why medical research charities are doing this and not pharma companies, that's also something we can discuss. So thank you for your attention. I look forward to any questions.
Well, thanks, Tian. That was really great as well. I've seen some really great questions in the chat box, so I'll just invite you to continue putting in your questions, and we'll go through those at the end. And now we have our last talk. This is from Professor Christi Deaton, who is going to speak on heart failure with preserved ejection fraction and addressing an unmet need in cardiovascular healthcare. Thank you.
Thank you very much, and good evening, everyone. So I am going to talk about what's sometimes been called the greatest unmet need in cardiovascular healthcare. I can get things to move forward. There we go. And that is a type of heart failure that's called heart failure with preserved ejection fraction, or HFpEF. And what we mean by heart failure is that the heart is not functioning as well as it should, and that it is failing to do the work that it needs to do. So it's a terrible term, but it's the one we have. So heart failure itself is a clinical syndrome. It's not a disease, but it is caused by other conditions. And patients generally present with signs and symptoms such as shortness of breath that may be indicative of heart failure. We look for structural or functional abnormalities in the heart. And inside the heart, there will be elevated intracardiac pressures and an inadequate cardiac output. So you're not meeting the needs of the body. Now, we tend to divide heart failure up by a term called ejection fraction. And that just means that that is the proportion of blood that's in the ventricle that is then ejected by the heart when it contracts. So most of us sitting here are going to have an ejection fraction of around 65%. And we say that the ejection fraction is preserved if it is 50% or more. So it's in a normal or near normal level. And you've heard a lot about inflammation. And while this is less likely to be caused by atherosclerosis, which is what many have been talking about, it is related to inflammation. So one of the theories about HFpEF is that it is set up by systemic pro-inflammation that is caused by these conditions, comorbidities such as obesity, diabetes, and hypertension. Now, when a patient presents, we do a number of studies. One of those are blood tests. We look for natriuretic peptide rise, and we usually do an echocardiogram to look for those structural or functional abnormalities. But with HFpEF, this can be much more difficult. So it can be very difficult to diagnose. And previously, we have had fewer treatment options. So we can manage fluid, we can manage their comorbidities. There's certainly increasing evidence around exercise as a treatment. And only recently have there been really some drugs that have shown that they can improve some of the outcomes for patients. So a drug, SGLT2 inhibitors, that was actually developed for diabetes has been shown to improve heart failure hospitalization. And there's weaker evidence for some other drugs. But being interested in this group of patients, because they are actually about 50% of our heart failure patients, and they are increasing in prevalence as our population ages and as we live with more comorbidities. So I lead a program of work called Optimize HFpEF for short. And we've had a number of work packages where we really wanted to understand what was happening in practice, who the patients were in the community, because they're not usually the same patients that you find in clinical trials. And we wanted to understand what were the problems that we were encountering, because this is a very under-recognized group, and what might be solutions for that. So we recruited a cohort, mainly from primary care. It was very difficult to find these patients because they're not usually labeled as HFpEF in primary care. And of those that we recruited, we could confirm that 61% did have HFpEF. And as you can see from this, they're mostly an older group. They have a lot of comorbidities, very high rates of obesity and overweight, and about 2/3 of them were pre-frail or frail. About a quarter were frail. They were very functionally impaired, so less than 300 meters on a 6-minute walk test is considered very impaired. They took a lot of medications, but they weren't very often referred to cardiac rehabilitation. We also talked to a lot of people. We interviewed over 140 providers across different healthcare sectors. We interviewed patients and carers, and really to ask them about the kinds of problems that we were seeing. And you can see some of the quotes here, kind of a lack of guidance, lack of really thinking that there was anything that could be done for patients, and patients actually being told that there wasn't anything that we could do for them, and just the protracted diagnostic process that occurred. I think I'm going to skip this, but this is just some activity monitoring that we did with this patient group. But you can see that higher levels of activity, what might be moderate levels of activity, very little time was spent. They were mostly sedentary. So in a sense, we saw it as people presenting with signs and symptoms that may indicate heart failure. And it was almost like entering a maze. So there were a lot of blind alleys, there were a lot of dead ends. So many of the symptoms that patients have are not specific to heart failure. So it can appear that could be from a number of other causes. And some of the tests that we do, the way they're interpreted, access to services and those kinds of things can all cause problems, for a patient getting to correct diagnosis and appropriate management. So where we are with Optimize HFpEF is our work is looking at specific interventions that we can use. So we're particularly interested in the non-pharmacological. So for example, a blended nutrition and exercise intervention. And this would help us address some of the problems these patients have with frailty and the loss of muscle strength, which of course will increase their risk of falling. We're also part of a clinical trial that's looking at home rehabilitation. So how we can get more patients into rehab by actually facilitating it in their homes. The other work that we want to do is very much downstream from what people have been talking about, and that is about looking at our healthcare system. So how can we deliver healthcare in the most efficient and effective way? So the interventions that Nick and Mary and Tian have been talking about, how can we make sure that those are actually, when they're available, going to be delivered to patients throughout the country? So taking more of an engineering approach, so health services research to ensure that patients have a shorter time to get appropriate diagnosis and everyone knows what's going on and they get appropriate management. So that's where our work is, very much downstream, looking at non-pharmacological interventions and how we engineer healthcare in a very resource-strapped health system. So our goal really is to smooth out this pathway so that patients don't get lost in a maze, but they get much quicker diagnosis and treatment of this condition. So I just want to acknowledge our funders and the other universities that have been involved in the Optimize HFpEF study. So thank you.
Okay, great. Well, thank you again for another really excellent talk. So that brings us now on to the panel discussion component of the evening. And what I'll do is I'll start with one or two sort of broad questions, and then I will go through all the great questions we've had through the comment boxes. So if I could just start by asking a general question to the panel. There was a lot of talk about inflammation and how specific inflammatory drugs might help us in cardiovascular disease. How close do you think we are to being able to use these drugs in clinical practice, and what are the hurdles that need to be overcome to get us there? Open to any of the panelists.
Well, I'm happy to kick off, and I'm sure others will join in. I think, as Mary alluded to, there are drugs that have shown clinical benefit already. However, they've been quite potent in targeting the certain parts of the immune system called the innate immune system, which is neutrophils and macrophages, and they're quite important in infection. And as Mary alluded to, infection has been an issue in these drug therapies. And I think as we become more nuanced in our understanding of different parts of the immune system, we can try and target other parts of the immune system and more selectively at certain time points which are more relevant for the disease process, and hopefully develop therapies which are overall beneficial for patients. Certainly things like colchicine can be used at the moment, but very few people are using it. But I think it will still take time for certain treatments that are more precise to come through. And I know there's just trials going on internationally on various pathways that people are targeting, and we're talking about next sort of 5 years probably these are coming through.
I'd agree with that. I think this is one of the real sort of benefits of drug repurposing, is that actually it's a known quantity, we know its side effect profile, and actually we can move things fairly quickly then to getting to the sort of larger stage 3 and larger stage 4 RCTs. And then my other slightly sort of philosophical, provocative thing is we have seen this with COVID, and we have seen sort of drug repurposing happen actually at scale very quickly. And actually cardiovascular disease represents as big a challenge. And actually we need to be in sort of utilizing some of the setup that we've seen recently in COVID to really kind of push this forwards.
I would also like to add only one, because in general, as this is a panel discussion, just to have some discussion, because you are both talking about more general drugs targeting very general, a lot of cells, and in general, the inflammatory component with this repurposing of drugs. I think that for the drugs that, for example, I was talking about that are more individualized, and I think that we are like maybe in 10 or 15 years, we will start be able to using them, but yeah.
Great. Okay. Well, thanks very much. So I'll just go pretty much in order of how the questions came in the chat box now. So it'll go by speaker initially, and then we can open it up more broadly. But please, anyone chip in as you wish. So the first question was to Dr. Nuss. The question was, are there any molecules already that are being tested targeting those specific cell receptors? So I think that's referring to the B cells and the T cells. So anything that's already in use.
Yeah, so mostly they are targeted for the T cells, and it has been a few weeks just published a paper in a lab in US by Epstein, that they were using nanoparticles targeted to CD5 in the T cells, and they were doing CAR T cells in vivo. These were in mice studies for treating heart failure, but definitely it's a good starting point. So the idea, I mean, these nanoparticles, they can work, and it will be easy also to make them work in humans. That for our approach and to translate it in my research, the idea will be to find, because this CD5, it binds to some T cells, so the idea will be to find how this T follicular, which molecules are necessary for this T follicular helper differentiation, so you can target the naive cell to be able then to create a T follicular helper cells with the properties that you, with more protective properties and without affecting their infection, anti-infections ability. For the B cells, the thing is that they are generally these nanoparticles are used just to induce an antibody production. So none has been derived to target any receptor on the B cell yet.
Okay, great. Thanks, Mary. And so the next question, moving on to Nick. So the question is the intention, if the clinical trials with valproate and minocycline show effectiveness, that these could be used without using expensive PET scans?
Short answer, yes. PET is a fantastic tool for being able to tell us the extent of the mechanism and how well the drug is working. But in terms of then the next step will be actually doing it at scale in a large clinical population where actually we wouldn't anticipate using PET. Obviously, the ideal would be if we could come up with a robust biomarker that means that we don't need to use PET scanning and could do it with a blood test, then that would save then from the point of view of radiation exposure expense and so forth. But yes, the larger thing will be taking it forward then to a larger clinical based RCT. So it's a randomized control study.
Yeah. And there's a very specific question for you. What dose of sodium valproate are you using in your study?
So I saw that one. It's 400 milligrams twice a day. So it's at the lower end of the dose that we would normally give for epilepsy. It's also a drug that's used for migraine as well. So it's at the lower end of the dose.
Great. So next for Tian, there's a question about how the immune cells get into the plaque.
So there's a barrier over the plaque, and when there's inflammation, when the plaque develops, this barrier becomes leaky actually, and the cells, the barrier starts to express molecules which actually pick up immune cells that are traveling in the circulation and then draw them in through the barrier into the immune cells, and we can see that. In animal models, but we also see evidence of that in humans. So immune cells transit through from the blood.
Great. And another question, is there any research being carried out on diagnosis and treatment of coronary vasospasm? Are you aware of any ongoing trials?
Yes, there is an area of interest. So patients who have had a heart attack, we know that by the fact that they've got heart damage on their blood markers. When we take them to the cath lab, we look at their arteries, they don't have any plaque. And one of the real causes of that, and one of the causes is vasospasm. And we know about maybe a fifth of patients don't have plaques that are causing their heart attack. So there's work being carried out. There's some research being at Papworth as well, looking at vasospasm. And there's certainly, I think one of the biggest groups is up in Glasgow, with Colin Berry looking at vasospasm. Firstly, trying to diagnose it, and also what the best treatment is.
Okay. Just following on from that, it says, how is IL-2 different from IL-1, and any benefits of targeting IL-2 versus IL-1? Yeah,
the immune system has a lot of interleukins, the different ones. They're numbered from 1 to and they keep on going up. And they're just immune hormones the immune system uses to talk to each other, to signal to each other, and to relay messages. And IL-1 is one of the potent inflammatory messages that the immune system uses to relay, hang on a minute, we need to really up inflammation here, there's something going on. And that's what's been targeted so far in some of the larger studies that have been published. IL-2 is slightly different. It's also at higher doses used to activate the immune system, but at lower doses can activate the anti-inflammatory parts of the immune system.
Great, thank you. And now moving on, question for Professor Deaton. It says, what would your ideal scenario for non-pharmacological intervention packages for patients with heart failure with preserved ejection fraction be? And how effective would you say they could be with non-pharmacological intervention, or do you need to combine both of them?
Well, I think you would need the combination. I mean, if you notice it's very clear that with the SGLT2 inhibitors, that while they improve quality of life symptoms and have dropped heart failure hospitalization, this is a group that has a lot of multimorbidity. So we need to address everything. And that's what another part of the healthcare system that I think we don't do as well is around how we manage people with multimorbidity. And then the non-pharmacological, the exercise, helping people start to lose muscle strength, muscle mass, they become frail. There are a lot of issues that they can't do the things that they want to do. And that's where the non-pharmacological are particularly helpful in that. So I think it's a good combination. And the one thing about now having a drug is it really shines a spotlight on this conditions, because suddenly there's a lot more interest in, oh, well, there's a drug, so we should be diagnosing this condition. So I'm grateful to the studies, not only for the effect they're having, but also because they're raising a lot of awareness about HFpEF.
Great, and just a follow-up that's just come through from the question and answer box. It says, I'm one of a group in Gamingay, which will be reopening our community gym. I'm very keen to promote the health benefits of exercise and would appreciate any guidance and promotional material to encourage more people to use the gym facility. So is that something that anyone has any resources to that we could help here? Any advice?
I think that the VHF has lots of, in their website, have lots of different advice, and I think there is some for exercise. Yeah. If they look at the VHF website, there are recommendations for everything. that they are very useful and very for all the public in general. Yeah, the British Heart Foundation website.
And similarly for the Stroke Association as well, Bob.
And I think if you also work with cardiac rehabilitation programs, so once someone has finished a rehab program, they need those community programs. And sometimes you do need to have someone who's got proper training for dealing with patients who have heart disease. But it's maintaining that exercise, because once they leave rehab, you want them to continue that exercise or those, the things that they're doing that are helping them.
Great, thank you. And I'll just continue on with the questions now. So there's some more sort of general questions specifically about different drugs. One question is, what role are anti-obesity drugs going to play in primary prevention of heart disease? So I'll open that up if anyone wants to tackle that one.
I think in the last couple of decades, cardiologists have been trying to be focusing on lipid quite a lot, and I think in the next couple of decades, we'll be focusing on diabetes and obesity a lot, and trying to tackle that. For example, Professor Deaton can testify that recently GLP-1 was shown to be useful not only as a diabetic drug but also for weight loss, and as a result, I think that's opened several avenues for us from certainly from a cardiology point of view. But at the moment, I think there's certainly development of anti-obesity drugs, some of which is going on in Cambridge, but nothing is clinically used really.
Sorry.
No, I'm sorry. Go ahead, Mary.
Yeah, I just wanted to mention that orlistat that is really used for obesity. It was shown to have a very beneficial effect in the reduction of cardiovascular risk. And the only thing that I think that also it may be important to see what is the impact of these drugs in the immune cells, because the immune cells have, and we are studying this in some members of Professor Malat's group, what are because the immune cells also have receptors for leptins and for other molecules that are related to obesity. So we should also take this into consideration for patients with residual inflammatory risk.
I was just going to say that underlying all of the talks, I think, is a clear primary prevention message. I mean, it's estimated we can prevent 80% of heart disease through prevention by addressing the risk factors and by preventing the development of high blood pressure, type 2 diabetes, and so forth. So I think any of those things could potentially be really important.
And it would be great if we could, and I think Professor Deaton has already alluded to, shift more focus on trying to prevent obesity, not with drugs, but with lifestyle changes. Now, some of these drugs coming through, some of which I prescribe, cost hundreds of pounds a month. And can you just imagine what you could do with that sort of money if you could, get gyms and trainers and all sorts. And we need to really think about what we're doing and how best to manage the patient, not just with drugs.
And I think going back to that metabolic syndrome and the idea of obesity, the metabolic syndrome that it entails there is linked with inflammation. And Christi and I see this with frailty. So, for example, is that actually vascular inflammation is associated then with clinical frailty, the overall loss of homeostatic reserve. And actually, so I think all of this atheroinflammation, this inflammaging has very important implications, not just for cardiovascular disease and stroke, but actually healthy aging as well.
I think we shouldn't forget here that there is people that have also genetic factors that made them have obesity. And the same for people that have autoimmune diseases and that even they are taking drugs that are with a lot of side effects. So these are going to still have high cardiovascular risk and maybe obesity. We also need to take them into consideration. So drugs are necessary too.
Not for the vast majority of people.
Okay, well, I think we're just going to run over for about 5 minutes because we started late. So I'll just make sure we have a chance that everyone gets their questions answered. So the next question is about aspirin and its anti-inflammatory action and whether that is thought to be beneficial in cardiovascular disease.
I think it certainly aspirin at high doses have an anti-inflammatory disease. In mice, it certainly does have anti-inflammatory properties. In the doses used in patients, it probably doesn't have much of an anti-inflammatory effect. We're mainly thinning the blood by inhibiting platelets, which cause clotting.
Great. And next we have a question about heart failure with preserved ejection fraction. So would cardiac myosin activators such as omecamtiv mecarbil have any benefit in patients? I think there have been some trials about this recently. I don't know if anyone wants to field that one.
I can't answer that one, so I'm happy if anybody else has a comment.
It's been looked at. So as Jason suggested, there was some trials recently, and I think there is some hope that this may be a second line of treatment for patients with HFpEF.
Great. And Tian, another one for you. It says, do we know if the similar immune processes that affect the main coronary arteries would have a role in the pathological process that leads to increasingly recognized myocardial microvascular circulatory disease, i.e. MINOCA? So is inflammation involved in microvascular disease?
Well, this is an area of active research, and Papworth is involved in this. And the short answer is we suspect so, but we don't really know. It's something area that we're going to look into. Probably yes, but we just don't have the data in patients at the moment for it. But it's a very good question, and it is an area that will need to be addressed as more and more patients. You know, there's some data suggesting that microvascular obstruction is linked to obesity and diabetes, and this is also going to increase in prevalence with time in our populations.
Great. And now we've got a question for Dr. Evans. So Hai Peng from Coventry University says, I'm currently working on the geometric analysis of atherosclerotic plaques. Can this be combined with your technology to triage vulnerable plaques?
So I think that's a really interesting question. We, at the moment, within conventional stroke care, we look at the degree of narrowing, the degree of stenosis, and we basically just look at whether it's 50% stenosed or more, so 50% narrowed or more, and that determines then whether or not you go for an operation. There is so much more to be done in terms of risk stratifying plaques through, for example, plaque geometry, for AI, and better detection then of being able to say which ones are cold plaques, which ones are hot. So I think there is definitely scope then to be able to combine plaque morphology, the way it appears, and plaque physiology, the way it's behaving. So yes, the short answer is absolutely. And certainly I would be very happy to be contacted if you wanted to discuss more.
Great, thanks, Nick. So that's it for all the questions in the chat box. We still have a few more minutes. Maybe I'll just open it up to the panel again with maybe one last question.
Jason, I think there's a question about pricing of repurposing, which I thought was quite...
Apologies. Let's go with that one then. Sorry. Yes, it says, how would repurposing of the drugs work with pricing that NHS or other payers would need to consider for those new old treatments? So if anyone wants to take that one on.
I can try and go first. So something we've considered quite a lot with as we're sort of developing these treatments and repurposing them, how to fund them. So for example, drugs that have been repurposed remain cheap because they're off patent, and if generic companies pick them up, they can carry on producing them. But one of the issues is how to fund these studies. For example, as some of my studies are going into later phase studies, and hopefully Nick's as well, who funds them, right? Because they're multi-million-pound phase 3 studies with hundreds and thousands of patients in them. Usually they're funded by pharmaceutical companies who can therefore invest and make profit from them. But if there is no pharmaceutical company to back you up, and at the end these will be cheap treatments, who funds that? And then that's one of the issues that researchers like myself and Nick, who want to repurpose drug, come across. The whole idea of intellectual property. Well, there is potentially intellectual property, but if they're off license, how do we get that intellectual property, and and who funds it, and it's not an easy question to answer actually. Some of the medical charities may help you, but it's a big ask to fund these multi-million-pound studies.
Yeah, that's a great answer. Thanks, Tian. Okay, so I guess let's wrap things up now. If anyone has any final questions, you're welcome to either ask them now, or you can contact Cambridge Cardiovascular email, and we'll be happy to to get back in touch with you with any specific questions you might have for our panelists. And I'd just like to thank Dr. Tammy Dugan and Vicky Reed for organizing this event on behalf of Cambridge Cardiovascular, and thank everyone who participated in these discussions and all the panelists. Thank you very much, and good night.
Thank you for coming. Thanks, guys.
Bye.